So one of the top 10 global public threats is antibiotic resistance. Besides causing severe sickness and suffering, the cost of antibiotic resistance to the economy is significant. Also, without effective antimicrobials, all the progress that we are so used to embrace within the medical field will be jeopardized. But there is hope. With an increasing global awareness of the immediate need of actions and countless local initiatives around the world showing that the negative trend is possible to reverse, we might stand in the beginning of a new era. And we are delighted that we are able to have with us Her Excellency Minister for Health and Social Affairs in Sweden, Lena Hallengren, to deliver the first of the introductory keynotes, which we have tied to the topic Antibiotic Resistance, the Silent Pandemic. Welcome.
Dear Excellencies, distinguished delegates, ladies and gentlemen. My name is Lena Hallengren and I'm the Minister for Health and Social Affairs in Sweden. I'm sorry that I'm not in Dubai with you today. However, I'm very proud that we have had such a prominent delegation representing Sweden during the Health and Wellness Week at EXPO 2020. It really shows the very broad spectrum of knowledge and excellence that Sweden has to offer. And first of all, I would like to extend my belated congratulations to the United Arab Emirates on the occasion of its recent 50-year Golden Jubilee and for successfully hosting EXPO 2020. The pandemic has shown that health is the foundation of functioning and wealthy societies. During the pandemic, the healthcare systems in our countries have been placed under strains that are unmatched in modern times. Economies have been severely affected too. At the same time, several important lessons have been learned and adjustments have been made in the way we work. Sweden continued to make large investments to strengthen the healthcare sector. This includes investments in further training for healthcare staff and funds to manage postponed care due to the pandemic. We also initiated large-scale restructuring of the Swedish healthcare system, in which strengthening the primary healthcare is a key component. Strengthening primary healthcare is fundamental for a well-functioning healthcare system and for public health. Improving capacity for early diagnosis will create better conditions for early treatment, prevention, self-management, as well as lower costs for treatment. This has been clearly demonstrated by the COVID-19 pandemic. Moreover, the pandemic has clearly illustrated that cooperation is key when dealing with cross-border health threats. To tackle global health challenges such as antibiotic resistance, lifestyle-related diseases and rapidly aging societies, we will need to work together between sectors as well as between countries. We need to increase efficiency and quality for all, for example by adoption of innovations and new medical advances such as precision medicine and the transformation towards a more digitalized healthcare. I know that the UAE has adopted a national strategy for well-being 2031 with the aim to integrate the concept of well-being. This is quite similar to the Swedish approach that can be the basis for our dialogues moving forward. My hope is that we, the life science sector in the world, can keep the same speed and engagement with which new and safe vaccines against COVID-19 were developed going forward. The same speed must now be applied to develop new, safe and effective healthcare solutions and methods that can increase the quality of life and well-being for our citizens and achieving the goals set in the 2030 agenda. Now, I would like to say a few words on the topic of this panel, antibiotic resistance, the silent pandemic. I'm very happy to be a part of this important panel today and to be joined by such prominent participants. Taking the time to discuss antimicrobial resistance and infection prevention despite the ongoing pandemic shows the commitment that is needed in this fight. Antibiotic resistance is often called the silent pandemic, but AMR is as ever real as the ongoing COVID-19 pandemic. New research published in The Lancet in January this year indicates that AMR actually is even more deadly than we have known earlier. The new estimate is that more than 1.2 million died in 2019 as a direct result of AMR, according to the most comprehensive estimate to date of the global impact of AMR. This underlines the importance of continued and enhanced efforts from all parts of society. Political leadership from the very top and from different sectors is crucial in the fight against AMR. The Swedish government has put the effort to combat the silent pandemic of AMR at the core of our agenda, both nationally and internationally. Sweden is actively working with the UN One Health Global Leaders Group on Antimicrobial Resistance, where I am proud to be the Vice Chair. Sweden is also a founding member of the Alliance of Champions Against AMR. These groups provide excellent platforms for collaborative action and continued and future action in our fight against AMR. Sweden has reduced the prescription of antibiotics in the outpatient care with nearly 60% between 1992 and 2020. And we have among the lowest rates in the world. Let me mention one thing that has been particularly successful in Sweden. That is to reduce AMR via close cooperation and dialogue with the prescribers. The interdisciplinary organization STRAMA, which is a Swedish acronym for Cooperation Against Antibiotic Resistance, has promoted responsible use of antibiotics since it was formed in 1995. These achievements in the AMR area can be attributed to committed work among many different professions and areas in the society according to a One Health approach. Collaboration is important, but it is not all we need. Financial contributions by more countries is also needed, preferably to the tripartite multi-partner trust fund, in order to support low and middle income countries to develop and implement action plans on AMR. My hope is that today's panel will stimulate each key stakeholder group to act and contribute to managing the threat of resistance. I also hope our session will contribute to new partnerships between stakeholders and ultimately new innovations that will help us combat AMR. Ladies and gentlemen, this program is part of EXPO 2020, and I therefore want to acknowledge the importance of World Expos. For 170 years, World Expos have provided a platform to showcase the greatest innovations that have shaped the world we live in today. I would therefore like to extend a warm welcome to all of you. Welcome to co-create with the Swedish healthcare sector for a more resilient healthcare systems for the future.
Thank you so much, Her Excellency Minister Lena Hallengren. And our next introductory keynote is with us live but virtually as well, and that is Ahmed Mandhari, who is WHO Regional Director for Eastern Mediterranean. And I hope that you will share your screen with us as well, and the floor is yours.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum and very good morning, colleagues. Thank you very much, Madam Moderator, for introducing me. And it is my great pleasure and honor to join you in this very important meeting, as Her Excellency and Her Royal Highness have mentioned. It is an issue that is of common interest to us all, and we have no escape out of it, and we have to discuss it and take it further in order to make sure that our current and future generations will enjoy the best high-level quality services from our health systems. That will include definitely promotive, curative, rehabilitative services. In my brief notes, I'd like to share with you 3 main areas that are relevant to AMR linked with COVID-19, as have been mentioned, the silent pandemic. I'll talk just briefly about the background, and then I'll share with you very key points about the COVID-19 and AMR, and then I'll just go and speak about AMR in Eastern Mediterranean region. As we all know, AMR is a global health and development threat. And on this regard, in fact, WHO has declared that AMR is one of the top 10 global public health threats facing humanity. It is known that misuse and overuse of antimicrobials in the human health sector, as well as in the food production and animal sectors, are the main drivers in the development of drug-resistant pathogens. In addition, lack of clean water and sanitation and inadequate infection prevention and control, promote the spread of microbes resistant to antimicrobial treatment. We all know that at the same time, the cost of AMR to the economy is really significant. In addition to death and disability, prolonged illness results in longer hospital stays, the need for more expensive medicines, and financial challenges for those who are impacted by this AMR. On that area, in fact, new estimates from the global burden of bacterial antimicrobial resistance in 204 countries and territories in 2019, it has revealed that at least 1.27 million deaths per year are directly attributed to AMR, which require urgent action from policymakers in the health community to avoid further preventable deaths. The new data, in fact, shows that AMR is leading cause of death globally, even higher than HIV, AIDS, or malaria. The world is not doing enough to address AMR, and our current action plans are not really, ambitious or fast enough to control the threat. And AMR is already putting extra pressure on frontline healthcare workers, as have been shown by many studies in different parts of the world, by making common infections harder to treat and preventing them from saving millions of lives. We have seen it, we all have come from hospitals, and we have seen how much suffering those frontline staff are really facing on their day-to-day practice. A continued rise in the resistance by 2050 would lead to 10 million people dying every year, and a reduction of 2 to 3.5% in gross domestic product. It is also estimated that the cost of antimicrobial resistance could reach up to $100 trillion globally if the growth of antimicrobial resistance is not shown, or slowed today, and shown an interest to slow it down. This definitely will lead to the conclusion that without effective antimicrobial resistance programs, the success of the modern medicine is in treating infections, including major surgeries and cancer chemotherapy, would be at risk. Furthermore, AMR requires urgent multi-sectoral action in order to achieve the Sustainable Development Goals, as have been mentioned by Her Royal Highness. Now, when it comes into AMR during this COVID-19 era or pandemic for the last 2 years, as we all know, the pandemic resulted in an increased use of antibiotics, and this may contribute to further emergence of antibiotic resistance, in different parts of the world. The second point here, is the global response to the COVID-19 pandemic is considered as an opportunity to strengthen health systems, including specific activities such as antibiotic stewardship, infection prevention and control program measures, WASH, and immunization that also help to prevent the control and the emergence and spread of antimicrobial resistance. AMR, as we all agreed, poses a public health threat with long-term negative humanitarian and economic consequences. failure to systematically include AMR specific activities in the COVID-19 response will definitely undermine the global fight against AMR. And I'd like us to conclude by sharing some few key points about, EMRO, Eastern Mediterranean region, when it comes into AMR. AMR here in the region is considered as one of the priority areas, programmatic priority areas in the EMR vision, Health for All by All, 2023. And we have 22 countries, and all of these countries in the region have completed or endorsed their antimicrobial resistance national plans. And all the 22 countries, in fact, have enrolled and reported AMR data to the WHO Global Antimicrobial Resistance Surveillance System, GLAS. Now, although we have important achievements in the region, yet AMR data reported to GLAS showed high burden of multi-drug resistant bacteria causing bloodstream infections, where 70.3% of bloodstream infections are due to carbapenem, for example, resistant anti-Acinetobacter species, and 66% are due to Klebsiella pneumonia resistant to the third generation of cephalosporins. The prevalence of antibiotic prescription among hospitalized patients is ranging from 38 to 77%. The high burden of AMR and antibiotics use is really challenged by limited capacities in implementation of national antimicrobial stewardship programs and infection prevention programs, prevention control programs. We need to recognize the importance of infection prevention and control programs as a key pillar in health system strengthening, with cross-cutting values to reduce the spread of AMR and other infectious diseases. Otherwise, we will face the difficulty that we are facing now and the years before. Now, while the COVID-19 pandemic led to the recognition of the importance of IBC, many countries, unfortunately, in the region and the world have yet to establish and enhance their own IBC national programs. Through investing in IBC, we will definitely need resources. The COVID-19 pandemic demonstrated that such investment will be highly cost-effective to prevent spread of infections among patients and healthcare workers, in addition to reducing infections caused by resistant strains. In this regard, here in EMRO, in fact, Oman requested WHO in the last AB 150 meeting that was concluded last week, the importance of developing a global IBC strategy in collaboration with all member states. And I'd like us to conclude here by, how much WHO is providing technical support to member states here in EMRO, in the region, to implement national prevention activities. And these activities, will include strengthening national antimicrobial stewardship programs to promote appropriate antibiotic use, establish or enhance national IBC programs to reduce the spread of AMR in healthcare settings. We are also supporting expansion and access to vaccines and clean water and sanitation to prevent infections in collaboration with other UN agencies, like, for example, UNICEF. And last, we are also providing, the required capacity building in all areas of AMR. That will include definitely surveillance, microbiology laboratory capacity, IBC, stewardship, programs, data management, and many other activities that we need to conduct. I'm sorry if I took this much time, but it is really a very interesting topic. I'm pleased and honored to participate in such a discussion. Thank you very much for giving me the chance. Back to you, Madam Moderator.
Thank you so much, Ahmed Mandhari, for giving us these perspectives. The importance of global health has been obvious as has been pointed out the past 2 years. And to talk more about the present situation, the future challenges, and how to tackle them, we are delighted to have Professor Benedetta Allegranzi with us, who is technical lead of infection prevention and control at WHO. And you are with us virtually, and I hope we will also hear you. Please give us your thoughts.
Good morning, everyone. I would like to check if you can hear me, first of all.
We can.
Okay, that's great. Good morning, everyone, again. Many thanks to the organizers, in particular to the Swedish government, not only for organizing this conference, but also for all the support provided to WHO, and I'll mention this later, in particular at the end of my presentation. Let me start now by presenting, actually, and I hope you can see my screen. Can you confirm, please?
We do not see your screen. We see you, but not your screen right now.
My screen is on at the moment.
It's all working.
See that? Okay, fantastic. Thanks a lot again. So, as I was saying, I wanted to thank, in particular, the Swedish government for all the support on antimicrobial resistance and also many other matters to WHO. And I will explain this also at the end of my presentation very briefly. So first of all, I'm talking about the issue of healthcare-associated infections, which affect worldwide hundreds of millions of people every year, as estimated by WHO, many of which are completely avoidable. And according to our data, we know that no country or health system, even the most developed and sophisticated, can claim to be free of HAIs. So worldwide, we estimated that 1 in 10 patients is affected by this problem on average, and 1 in 10 of these patients who are affected dies of HAIs. Some years ago, we performed meta-analysis where we found that on average in high-income countries, 7% actually of patients are infected by HAIs, and the double is in low middle-income countries, in acute care hospitals. So not considering long-term care facilities, primary care, and other settings where healthcare is delivered. Then last year, we published a global report on sepsis, where we found that 1 in 4 cases of sepsis is healthcare associated. And in particular, in patients in ICU, the 49% of sepsis with organ dysfunction is hospital acquired, with a mortality, crude mortality, which goes up to 52%. And if we look at neonatal infections, this is which are healthcare associated. This is a major problem in low middle income countries, but also in high income countries. But in low middle income countries, there are 3 to 20 times higher incidence of these infections. And in fact, healthcare associated sepsis in neonates is 7.5 times higher than in adults. Sorry, I'm trying to move my slides. Also, according to European CDC, now from a study between 2016 and 17, 8.9 million healthcare-associated infections occur every year in acute and long-term care facilities in Europe. So it's a major problem. And again, ECDC a few years ago highlighted that basically in terms of consequences estimated through disability adjusted life years, which correspond to the years lost due to premature mortality and years lived with a disability due to HAIs, these dailies account for twice the burden of all 32 other infectious diseases that are reported in Europe. And you see this graph, healthcare-associated infections are represented by the green bars here. This is very connected to AMR because other studies by ECDC estimated that 70% of dailies attributable to AMR in Europe are a result of HAIs. So there is a very close connection between the two phenomena, HAIs and AMR in healthcare. And we know that the mortality due to some specific pathogens, such as MRSA or those resistant to carbapenems, is significantly higher than in patients affected by the same pathogens but sensitive to antibiotics. And it has already been mentioned by Her Excellence, the Minister of Health of Sweden, that very recently, last week, there has been a publication in The Lancet looking at the global burden of bacterial antimicrobial resistance in 2019 and finding that almost 3 million people die due to AMR worldwide. And in particular, really the very attributable deaths when we can ascertain the cause due to AMR are 1.2 million. Another important point that I want to highlight today is the burden due to infection in health workers during the pandemic. So first of all, from this graph, you can see that clearly there has been a change in the burden due to can you still see my screen? I hope so. I wanted to say the burden due to COVID-19 among health workers has been really a big problem. At the beginning of the pandemic, very high, more than 10% in the first wave, and then declining to less than 5% of all cases of COVID-19 in early June 2020, and progressively under 1% since March 2021, thanks to the effect of the vaccination. But the global burden of deaths among health workers due to COVID was estimated by WHO, and up to April 2021, on average, it was certainly underestimated that there were at least 500,000 deaths due to COVID. I don't see, I think there is a problem with my slides. Can you confirm that you can see my slides? Because yes, there has been...
right now we see the slide with the global number of deaths among HWs, exactly. Now we see your presentation, the full one.
So there is a problem in the screen. Apologies. Okay, can you see again full screen?
We do not see now we see full screen again.
Okay. So basically, as I was saying, deaths among health workers due to COVID-19. A study which we funded really highlighted that there are specific risk factors that are related to infection prevention and control that contribute to determining these infections in health workers. High-risk exposure, not wearing a mask or a respirator appropriately, and also contact with an infected household member in a private setting, and Black and Asian race and Hispanic ethnicity. So moving to IPC, we know that this is a tried and true approach which is effective and cost saving, and there are 5 reasons to invest in IPC, which go from contributing to patients and health worker safety, to reducing costs, and also it's an approach that can be adapted and scalable locally. Linking to health infections in health workers, it has been clear that increasing training in IPC, adequate use of PPE, adequate hand hygiene, and universal masking were factors independently decreasing the risk of infection among health workers during the pandemic. There is a lot of evidence that HAIs and AMR in healthcare can be reduced through IPC from 35 to 70%, implementing IPC programs and interventions. Also, simply by hand hygiene, up to 50% of HAIs can be reduced. And that countries achieved important targets, such as in England, reducing MRSA up to 50%, and in African countries, in a study that we led, achieving 44% reduction in surgical site infections by implementing programs at the hospital level. And finally, IPC is cost saving, but it's also HAI. It's due to the fact that HAIs are really very expensive. In the USA, up to 15 billion were spent in HAIs for HAIs in 2016. Whereas OECD in Europe demonstrated that IPC interventions in healthcare and hand hygiene combined with antimicrobial stewardship can reduce by 2/3 AMR infections in healthcare, avoid up to 27,000 deaths, and reduce by 85% the health burden, with a saving up to €3 per capita every year. The reality is that IPC programs are really limited in implementation, especially in low middle income countries. Nowadays, still in 2020, according to data related to 2020, 33% of countries had no national IPC program. 35% only of countries had a properly implemented IPC program nationwide. And according to a survey that we are now concluding, basically only 3% of countries worldwide have a national IPC program which meets the WHO minimum requirements, whereas 80% of countries can meet up to 50% of the minimum requirements. It was also found by WHO that lack of IPC supplies and best practices was a major reason for people not accessing essential healthcare services during the pandemic in 44% of countries. It is true that through our survey, we also, however, found that there has been increased performance with some key indicators worldwide in the field of IPC. During the pandemic, in particular, more countries appointing a trained IPC focal point, more countries having a budget dedicated to IPC and having training. So this is good news, but still progress needs to be made. Because if we look at data at the facility level again, in 2019, we found that only 16% of facilities worldwide met all IPC minimum requirements, for instance. And we know that water and sanitation is a major issue, with 1 in 4 healthcare facilities lacking basic water, 1 in 3 healthcare facilities worldwide lacking hand hygiene facilities. And during the pandemic, in this sample of 6 African countries, we found that
Professor
only 1/3
Benedetta Allegranzi, sorry to interrupt you. You just need to conclude.
Yes, only 1 in 3 hospitals have all essential IPC supplies. So just in conclusion, the harm acquired where healthcare is provided should no longer be accepted. Several countries have been able to introduce IPC standards and progress, but wider implementation and sustained implementation beyond the pandemic is needed. We have a very good perspective, which was mentioned by RD Amro, which is that EB, with the contribution of the Swedish government, and I would like to take this opportunity to formally thank the Minister of Health, has approved the idea of developing a global strategy for IPC. And therefore, we have a brilliant future ahead of us with the perspective of improving IPC programs worldwide. Thank you.
Thank you so much. Thank you so much, Professor Benedetta Allegranzi, for showing us that this is both a very acute but addressable issue. And we will go back to Professor Otto Kars, I believe, and I think we will even hear him this time. Welcome back, Otto Kars.
Thank you. Can you hear me now then?
Yes.
Yeah, okay. Thank you very much for bringing me back. As an infectious disease physician, I witnessed the life-saving potential of antibiotics countless times. But over the decades, we have now seen how these miracle drugs have continuously lost their effect, and colleagues around the world, as we have heard already, are now struggling to treat multi-resistant infections. But as mentioned by the previous introductory speakers, we know now that the yearly death toll from such infections is over 1 million. But the consequences, in fact, reach much far beyond the many individuals that are dying. Access to effective antibiotics is completely necessary, fundamental of all health systems. And without them, procedures such as hip replacement, organ transplants, and cancer therapy will be jeopardized. I would say that, in fact, a zero vision for cancer is an illusion without effective antibiotics. Furthermore, antibiotic resistance is threatening the fulfillment of several of the sustainable development goals. I think that one reason for the present crisis is that technology development in the field of bacterial infections is far behind the development in many other fields of medicine. From the mid-1940s to the mid-1980s, the pharmaceutical industry was able to deliver novel antibiotics in a steady stream. But then the pipeline dried. And already in 2007, the industry declared that for many years they had been unsuccessful in finding truly novel antibiotics despite using sophisticated genomic target-based technologies. And this fact prompted a conference during the Swedish presidency of the EU in 2009, which in turn concluded that the innovation system was broken and new incentives from the public sector were needed. Although a number of initiatives have since been launched, global actions need to be much better coordinated. Many of them are short projects, and as a result, we still have no viable pipeline to replace those antibiotics that lose their effect due to resistance. So there is an urgent need for the public sector to provide leadership in championing new way forward to mobilize long-term public-private collaborations, perhaps even in the form of a global research institute, to overcome the scientific bottlenecks and ensure that new classes of antibiotics and alternatives are developed, and that sustainable access to them is secured also for everyone in need, regardless of where they live. Another barrier which we are facing when treating bacterial infections is the lack of rapid diagnostic tests. Today we are talking about precision medicine, not the least in the field of cancer. For antibiotics, we cannot really talk about precision treatment. The diagnosis still most often relies on bacterial cultures, a very old and slow technology, and even this basic technology is not available in any place in the world. And this puts patients at risk as well as driving unnecessary antibiotic use. So we have seen in the beginning of the COVID-19 pandemic how diagnostics became available in record time. And we need, in fact, the same sense of urgency when it comes to bacterial infections. as every hour's delay in diagnosis is increasing the risk of treatment failure and death. Antibiotics resistance need to be, it's not only a drug issue, it's not only an IPC issue, it's not only a regulatory issue, it's a systems issue. And it needs to be placed in a systems perspective, where prevention is key. And lessons from COVID-19 will be helpful, I think, as antibiotic resistance is also a pandemic, although much slower. Nothing is stronger than the weakest link, and health system strengthening, including mitigation of antibiotic resistance, must be a global collective responsibility. This also means that innovation is needed on how to engage the society more broadly, how to change behavior and social norms, how to engage professionals, and the whole of governments. Rich countries has a responsibility. Rich countries should commit, at least as a start, to reducing their own inappropriate antibiotic use by setting targets. And low and middle income countries need to be supported to strengthen infrastructure and capacity. And the latter is the purpose of the Multi-Partner Trust Fund on AMR, but unfortunately just a few countries have still pledged to this fund. And finally, the global governance to preserve effective antibiotics need to be placed on the highest political level possible. And it's great to see that the global leaders group, as mentioned by Minister Hallengren on AMR, is strongly advocating for antimicrobial resistance to be included in the forthcoming negotiations on a pandemic treaty. But sure, collective actions are urgently needed already now to meet this crisis. So with that, I wish you good luck with the continuation of this important panel discussion that will follow. Thank you so much for having me.
Thank you so much, Professor Otto Kars. Glad we could hear you. We will, as has been pointed out during this morning, the challenge with antibiotic resistance is enormous and it's acute and it is solvable if we work across borders in all senses. So in that, the collaboration between industry and society is crucial. And we are happy to share with you some words of the importance of collaboration from Ilze Melngailis, who is Senior Director, Business Council in the UN for Private Sector Engagement at the UN Foundation. Be my guest here.
Hello, I'm Ilze Melngailis. I manage the Business Council for the UN at the United Nations Foundation. I'm very happy to be with you here today just for 2 quick minutes to tell you about a couple of global multi-sectoral initiatives that are endeavoring to help stem antimicrobial resistance, one of the topics that you're discussing today. So 3 points really for you. The first is that the United Nations put antimicrobial resistance on the world stage in 2016 at the UN General Assembly. A lot of work has happened since then, but in the last year alone, a couple of interesting developments. One is the creation of a global leaders group, which is chaired by 2 heads of state and aims to really sustain political momentum and the necessary political will to address antimicrobial resistance around the world. Its participants hail from academia, from government. So Lena Hallengren is one of its esteemed members, as well as from nonprofits and from business. Merck, MSD, and Mars are they're the 2 companies represented on the Global Leaders Group. This year, you will also see the launch of a multi-stakeholder partnership platform, the first ever of its kind. And so stay tuned for that, because that will be an important mechanism for facilitating multi-sectoral collaboration. The second point I wanted to make is about the role of business. At the Business Council, what we have done is pulled together most of the leading global corporations who are working on AMR significantly. We are hosting a cross-industry working group on AMR, also the first of its kind, and our aim is to really support the leadership that the UN is mobilizing around AMR, but bringing the unique ability of the private sector to drive change. And through their expertise, their reach, their networks, and their unique capabilities. One example is a partner of ours, Essity, which is a Swedish company and a leading global health and hygiene and healthcare company. So yes, they do produce very important wound care and hygiene products, but maybe a lesser known contribution that companies like Essity make are to leverage their marketing skills and their reach through their value chain. So their ability to reach hospital administrators and healthcare providers and citizens and consumers through their considerable marketing and capabilities and networks. And so it's those kinds of capabilities that we aim to harness and to connect with endeavors led by the UN and other institutions around the world to really help drive progress. And the last point I wanted to make very quickly is around prevention, which is gaining momentum in the fight against AMR, and in fact was one of the 5 recommendations included in the recommendations that came out of the study that was reported in the Lancet just exactly last week on the 20th of January. Quite frightening results. I'm sure other speakers will share those with you today, but I just wanted to flag that prevention appears to be increasingly elevated as an incredibly cost-effective and an important way of addressing AMR as well as other global health issues. So in closing, I just again want to flag that the United Nations is mobilizing very important efforts to help stem AMR and to support the kind of work that you do. And it really is going to take all sectors, countries, and individuals to address this issue. So in closing, just want to thank you for listening and for your participation in today's session and for all the important work you do to drive progress. Thank you.
Thank you, Ilze Melngailis, for giving us some perspective of the importance of collaboration. On that note, I would like to welcome Farida Lundmark up on stage, who is a policy expert at LEAF, the research-based pharmaceutical industry Sweden.
Yes.
What difference would you say that the pharmaceutical industry can do in the fight against antibiotic resistance?
I would say that the pharma companies plays an absolutely crucial role in the fight against AMR. These companies are producing all the available antibiotics, and they are also responsible to ensure the global access to them. So I would say also in the light of the historically rapid development of the COVID-19 vaccines, it's very clear to me that these companies show both the competence and the commitment to really tackle these societal health challenges. One important initiative is the establishment of the Amr Action Fund, where several of the international pharma companies join forces to establish a sustainable and valid antibiotic pipeline. So that is sort of one way of attacking it from the industry as well.
Mm-hmm. And how well positioned would you say that Sweden is to take a leading position in this?
I would say that Sweden has the possibility to take the lead and be a leading country in the fight against AMR. And with the Swedish US presidency in 2023, we have a great opportunity to put AMR higher on both the European agenda, but also in the international agenda. And in an international context, Sweden has quite a favorable situation when it comes to AMR. And over the years, there has been remarkable work done by a number of stakeholders throughout the life science system with a clear commitment to reduce resistance, to raise awareness, and also to find new innovative solutions to fight the AMR challenge. So in that respect, I would say that Sweden is also well equipped to take lead on the work to preserve and enhance the value of already existing antibiotics, but also to try out different new models to incentivize R&D to find new antibiotics and vaccines. So I would say that we are in a very good position, and one way could be for Sweden to champion new payment models, for example, where monetary compensation is delinked from sales volumes. So I would say that we are in the right move to take a leading position.
So it sounds. Okay, and we will soon have a panel discussion here on all its pressing issues. And you will be back later today as well in a completely different discussion on early detection. But right now you at least have made a film about the how industry executives tell us a little bit more about how the pharmaceutical industry will work within the area of antibiotic resistance. So thank you for now, Farida. We will take a short look at your movie, and then we'll welcome up the panel.
The world benefits from today's major advances in modern medicine, but we may be losing the powerful tool that enables these advances due to a silent global pandemic that already kills around 700,000 people each year. The uncontrolled rise of superbugs due to antimicrobial resistance, or AMR. AMR occurs when a microorganism changes in ways that make existing medicines ineffective. This process is now happening faster than new antibiotics are being developed. And because AMR can affect anyone, of any age, in any country, it's a growing problem that requires collaborative action today. To help address this growing crisis, over 20 leading pharmaceutical companies have come together to invest over $1 billion through the Amr Action Fund. Together with others, this groundbreaking fund aims to bring 2 to 4 new antibiotics to patients by the end of the decade. Without new antibiotics, the health of future generations is in jeopardy. The Amr Action Fund is only part of the solution to accelerate the discovery of new antibiotics. So we will work with partners to create a policy environment that enables sustainable private investment into the pipeline. We have a critical opportunity to tackle AMR. Antibiotics save lives and are the foundation of modern medicine. Progress can't wait. We won't rest in the fight against AMR.
The coronavirus pandemic is teaching us many things, including that the world needs to be better prepared for global health threats. Antimicrobial resistance, or AMR, is just such a threat. Left untackled, it risks taking us back to a time when a simple cut could become lethal. At GSK, we have a proud record spanning over 70 years of researching and developing new antibiotics and vaccines to prevent infection. And we currently have 27 active R&D projects targeting priority pathogens. But we also recognise there is a systemic issue which needs to be addressed. We know the power of antibiotics to help patients, but there is limited funding available for research because the market doesn't reflect the value that antibiotics deliver to society and therefore doesn't incentivise investment. So that's why new models are required, and the Amr Action Fund is a great example of that. Working together in partnership, our industry is playing a core role in tackling coronavirus. I'm very confident we can do the same in fighting AMR.
The COVID-19 pandemic has been a stark reminder of the health and economic hardships of infectious disease. It reinforces the continuous need for new anti-infective therapies targeting newly emerging and difficult to treat infections. Yet, the market potential for new anti-infective therapies is limited and riddled with challenging economic hurdles. Because of the steep development cost, high risk of failure, and long lead times, there are few incentives to invest in R&D, since it will be difficult to realize a return. Despite this, Pfizer remains committed to patients suffering from infectious diseases. We continue to invest in and explore alternative pathways for expanding our pipeline across all 3 primary infection types: bacterial, viral, and fungal. And at the same time, we are working on creative solutions to help improve surveillance and stewardship. For us to do more as an industry to help stop the spread of AMR, changes are urgently needed to remove obstacles that are impeding a sustainable market. We recognize no one company alone can solve the AMR crisis. That is why creative, collaborative solutions are needed.
Infectious diseases are the second leading cause of death worldwide after heart disease and are responsible for more deaths annually than cancer. We are committed to help protect patients against the burden of COVID, influenza, and RSV. Antimicrobial resistance is a major public health threat. As we know, the misuse of antibiotics could lead to antimicrobial resistance. Our aim in reducing the burden of infectious disease is through preventive strategies, including vaccines, which in turn help to contribute towards the reduced use of antibiotics. Through working with a wider infection community, AstraZeneca aims to translate science into solutions to address global challenges faced in these disease areas.
MSD has a long history of research and development in preventing antimicrobial resistance. First, we are developing targeted antibiotics and antivirals to combat severe infections. Second, we have a worldwide surveillance program to monitor bacterial sensitivity to antibiotics, and we ensure that these data are published rapidly. And finally, we provide vaccines to prevent infections and thus limit the use of antimicrobials. Sweden is a role model for combating antimicrobial resistance because it had built a multi-sectorial collaboration to ensure sustainable use of antibiotics and to combat antimicrobial resistance. MSD Sweden and its medical team are highly involved in this important work. We look forward to a world in which antimicrobial resistance becomes more manageable.
Great. Yes, I think they are. Oh, let me. Welcome to the panel. I would like to you all to present yourselves and what you do, and also briefly tell us what you do in your daily operations in order to decrease antibiotic resistance. And maybe you could start, Björn Zoëga.
Yeah, my name is Björn Zoëga. I'm the CEO of the Karolinska University Hospital in Stockholm, Sweden. Shortly, from the hospital point of view, this is a challenge, as everything, and this is a challenge that is looked at in another way. We are more into the processes of doing the right thing and using digital health tools to do the right thing. So put in, when needed, the right antibiotic or not to do that, and have numbers to help us both look back and forward to predict and see if we're doing the right thing. And that's sort of what in the hospital environment I think is the way forward. So get the right processes in, get the right algorithms in to do that, and then you'll have some numbers to work with, and both to see if you were right and also to help all the physicians with a different level of knowledge to make the right assisted decision to do this.
Okay, thank you. And Dr. Johan Carlson, you could present yourself as well.
Yes, I'm Johan Carlson. I was until a few months ago the Director General for the Swedish Public Health Agency for almost 13 years. We've been heavily involved in antimicrobial resistance, been hosting Professor Carr's organization, working with prudent use of antibiotics in men, issuing guidelines, following up the system in Sweden, which has been rather successful, I would say. We've also been very much involved in healthcare-associated infections, surveillance, guidelines, conferences, and also on the global level, we've been hosting 3 conferences on glass indicator surveillance on the surveillance system on behalf of WHO and the Swedish agency. But I'd also like to point out was what Niklas Jakobsson mentioned in his opening speech. We've been also pushing very hard for the overall health measures. I would maybe a little bit provocative say that tobacco control, vaccination schedules are crucial also for antimicrobial resistance. Preventing diabetes, for example. These areas shouldn't be underestimated. Preventing people getting tobacco-related diseases like pulmonary diseases, preventing diabetes. This is something we are very much into. And it's less discussed, and it shouldn't maybe not discussed here. We concentrate maybe on IPC and other things, but we must bear that in mind, that the basic health promotional activities are also very important for antimicrobial resistance.
Keep people healthy to begin with, I guess.
Yeah.
Her Excellency Farida Al-Hosani, please.
Thank you. I'm really pleased to join this panel, and actually I work as the Executive Director of Communicable Diseases Sector in Abu Dhabi Center of Public Health. This is a local organization in charge of all public health programs in the Emirate of Abu Dhabi, and we work very closely with the Ministry of Health in UAE as well. So antimicrobial resistance is a very important topic to all and definitely to public health. We have a dedicated team who are supervising this program, and they have multiple aspects of the program, including the surveillance, setting the guidelines, working and training healthcare professionals about the updated guidelines. And we also work with different sectors, not only health, but also other stakeholders within the government and the private sector, to ensure that we deliver and minimize the impact of the antimicrobial resistance in the society. We work also very closely with the Department of Health, which is the regulator of health in Abu Dhabi, for the antimicrobial stewardship program, to ensure there is regulated use of antimicrobial by the physicians, by the private sector and public sector as well.
Thank you. And Ms. Amr Wright, please introduce yourself and what you do in your daily operations.
So my name is Emma Wright. I'm the Chief Medical Officer for Moonlica Healthcare. As an innovator, a developer of medical devices, infection prevention is very important to us. We feel we have a responsibility to bring products to market to tackle this issue, but those products also need to be cost effective. So we need to do our large-scale clinical studies, not just to show the benefits in reducing infection, but also the fact, as you've heard from previous speakers, that this can reduce the cost of healthcare. So we do real-world studies, we do individual studies at individual facilities in quality improvement programs, and also education. So a huge amount of education for both the clinical world and the patients themselves, to ensure they understand their role and their responsibility in infection prevention to improve their outcomes. It's a big challenge to get the global healthcare systems to understand the need to pay for prevention and not just treatment, and make sure the metrics are in the right places at the institutes to really value those benefits in infection prevention.
Thank you. And Ms. Gulnaz Tariq, please introduce yourself.
Thanks for having me. My name is Gulnaz. I'm working as Assistant Director of Nursing in one of the hospitals, which is 7 hospitals under SAHA. So as Farida said, and all the panel members, that prevention is the key, and COVID has really taught us either we want to or we have to. So now we are into a situation that we have to adopt to the change of and heading towards the prevention, not only for antimicrobial resistance, for anything and everything. So we need to go back to the basics and then start from a root level of educating everyone, everywhere, what is meant by all these prevention strategies when it comes to antimicrobial resistance, when it comes to infections in the hospital setting, when it comes to, for my background, for prevention of pressure injuries into, this population who is high risk or bedridden. So prevention is the key, but we need to collaborate. We need to develop teams speaking the same language. Then we can achieve at one platform, at one point of time, what needs to be done, but collectively. Thank you.
And Mr. Babak Rajnavadi.
Yes, good morning. Thank you for the opportunity. Actually, I'm the Business Development Director at the Getinge, Middle East and Africa. And I represent, let's say, the manufacturing side of the business. And on day-to-day basis, depending on the cases that we face, we try to initiate educational, let's say, programs for the hospitals, where we can increase the level of understanding of the nurses, of the doctors even, on how important it is to fight the hospital-acquired infections in terms of instrument processing, in terms of instrument management. And once, let's say, we have that platform of education checked, we focus on the process. So we always help with the hospital through consulting programs or day-to-day interaction to improve the processes. And of course, being a manufacturer, and since 1904, we have been manufacturing very high-end equipment for infection control and sterilization, contributing to the fight against the hospital-acquired infection. And the word today is digitization, and we monitor the whole process of, let's say, education, the process of the instrument within the hospital, as well as tracking the patient and the staff through our digitalized solutions that will all in all contribute to the fight that every panelist is discussing today.
Mm. You all seem to be quite focused on processes and helping people do the right thing, I guess. During the morning, we have had a lot of references to the COVID-19 pandemic, of course, because that's top of mind for all of us. But what would you say is the key learning from the pandemic response that can be used into this silent pandemic of the antibiotic resistance? Your Excellencies, do you have any thoughts on that?
Yes, definitely. I think there are many lessons learned, and COVID really reshaped and transformed our vision, especially the use of technology in different programs related to infectious diseases. So one of the lessons learned is really that the use of technologies, integration of systems, not only health-related systems, but also other systems, can help us to strengthen our antimicrobial resistance program. So definitely the prescriptions performance of doctors is already there in our electronic health records, but also integrating our systems with others. I think this experience with COVID-19 helped us to really learn more and get more engaged with non-health players, and it will help to evolve and update our antimicrobial resistance programs, definitely.
Björn Zoëga, you being the CEO of the leading hospital in Sweden, do you see the same?
Well, no, it's been different though. The lessons learned from the COVID-19 are being more like we're doing things faster and or using in a little bit the same way, using the numbers, using the data, being data-driven in another way that we sort of didn't do. We were more of a feeling that something was happening instead of data-driven. And this is what we are actually using more and more in different operations of the hospital, not only with the antimicrobiological problems, but so this has been our major lesson learned, that when you're extremely data-driven, you have success, and both to look at the history and both to make predictions going forward.
Dr. Johan Carlson.
I think it was mentioned before, but it's both ways in the pandemic. The pandemic has been problematic, of course, because of the breakdown of health services in many countries. On the other hand, it has opened our eyes for as mentioned by Dr. Terry, for the role of prevention. Prevention is a basis also for modern medicine. The healthcare systems of today in many countries are a response system. It's not a preventive system, but I think even the public and the politicians have learned that prevention must be the basis also for the healthcare sector. And the other thing, of course, is we need investments. All societies, the world have invested billions and billions of euros and dollars in this, and we need to invest more also in prevention and for example, antimicrobial resistance. That will do a big change.
We will discuss a bit more about changing behaviors and the impact that can have. But to begin that discussion, I would like to welcome Dr. Bishnu Panigrahi, who I believe is with us virtually.
Hi.
Welcome.
Thank you. I would like to first thank the United Arab Emirates and the government of Sweden to sort of have this session on redefining healthcare. And while we have been hearing about antimicrobial resistance, what I would like to present, which we have been doing in Fortis Healthcare, is about drug resistance index. This is a paradigm shift, if I can call it. It's a tool to monitor antibiotic consumption and this resistance pattern towards moving towards the antibiotical stewardship. So the main focus of our organization has been that we are focus driven, and we like to see that we measure what we are doing and to have a opportunity for improving. So we have different structures of going about it, which I've mentioned there. And coming to the antimicrobial resistance, everyone, we have been talking since morning about this and hearing people, and obviously it's a global healthcare concern. WHO has already mentioned it is one of the top 10 public health threats going around, and it is more of misuse and overuse. And there are a lot of combinations, fixed dose combination, using of rampant use of broad-spectrum antibiotics. And the other thing is actually which we don't take cognizance of it being given to in the animal food, because there's no sort of regulations there, whether you can prescribe antibiotics to like we have it for human beings. So I'll just come straight to the point of drug resistance index. What is it? It's a composite measure to evaluate the relationship between drug resistance and antimicrobial usage. So it combines the use and resistance puts it into a single measure, and it's something akin to the Dow Jones Index. So it shows you where you are, and it's an epidemiological tool, and it's a good communication tool for non-technical experts. A lot of times we have hospitals headed by non-doctors. So in 2015, we tied up with the Center for Disease Dynamics and Economics and Policy in Washington, and they advised us that they've been doing some work on this. How do you go about it? So since 2015 we did it, and since 2016, every year we bring out our DRI. And if you look at the DRI, it's a value from 0 to 1. 1 means that all the infections in that hospital will not be treatable by the antibiotics that are available. It's a horror story. 0 means that all the isolates that are susceptible to the antibiotics that are there, and so it is treatable. So it's a good way of looking at it where you are in that hospital, because it is hospital specific. It is not consultant specific or a department specific. It encompasses the whole hospital. So it is easy for the healthcare managers, policymakers, and the non-technical experts to see where the hospital is vis-a-vis antibiotic usage and antibiotic resistance. So it's to simplify, the resistance rates against consumption patterns is that what we look at it. To strengthen the AMS program and to favorably influence the prescription practices and promote rational use of antimicrobials. So if you look at it, it's that how do you calculate it? It is calculated based on the consumption of antibiotics and your antibiograms. So one of the most important things going forward here is that antibiograms is the cornerstone of this. So on most of hospitals do it 6 monthly, some of them do it yearly. So these antibiograms are taken up, and the complete consumption of antibiotics in the hospital, it is not department, that is calculated. There's a formula to it. So from this, the value is derived from 0 to 1. That is how we say that the DRI is calculated. So and 3 simple steps. It is preparing the resistance data, preparing utilization data, and collating the information and calculating the DRI. So this is how it is done. And every hospital, we have something called the antibiotic form that we have, which is a restricted antibiotic form. So depending on the hospitals, there are it varies from 8 to 10, 12 antibiotics, which are the restricted antibiotics. It doesn't handcuff any clinician to use it, but if he wants to prescribe it, he needs to give the indications, which is there. And we usually the dosage is prescribed as for three doses. So in other words, after the 3rd dose, if the AMS team do not approve it, it will not go to the patient. So the clinician will be involved in it. So, and what we did is unlike the Western world, most of our infections here are gram-negative. So these are the major major bacteria that we come across. We did a study over 20 multi-specialty hospitals, and the hospitals' bed strengths varied from 350 to as low as 135. So this is the most important thing that I would like to show is that if you, I've not mentioned the name of the hospital, so I've made it from A, B, C, D, and if you see the one that is circled in red, and if you look at from 2016 to 2020, the DRI has increased. What does it indicate? It indicates that the usage of antibiotics has not been appropriate. The resistance patterns are increasing. So this is a cause of concern. Then if you look at the one that is circled in green, there, if you look at it from 2016 to 2020, there is a slow decrease. From 0.38, we have come down to 0.18 in 2020, which is, it means that the way the antibiotics have been used has been rational. You have more firepower to take care of your the infections that come across, to take care of all the drugs that we have in our armamentarium. So in conclusion, what I'd like to say is that we don't have any external standards so far on the DRI. It measures the trend over a period of time. So a DRI compares, what we do is that there's the uniform calculation formula and data consistency across the hospital. So the hospitals are they have the data, they calculate it, and then we go we sit across and come to what needs to be done. So DRI as a utility, it is a useful indicator on the problem of resistance. It's a helpful tool for tracking and comparing effectiveness of available antivirals. Assess change in drug resistance over a period of time and across hospitals. So this is a very good trend you can see, and monitor compliance to AMS program, because the fulcrum of your antimicrobial stewardship is your AMS program. And using the DRI trends, you can customize your purchase of antibiotics. You can influence the prescription practices that I was talking about by using the restricted antibiotic form and talking with your doctors. And so behavioral modifications also, this is a change that you can put across. So this is what I would like to say is that DRI is a paradigm shift that we can look at it. And the most important message that I would like to give is that all these things, we should not look at it as a directive. It has to be participatory, and the participation has to happen at the hospital level. So these are good data points to share with the doctors, the nurses, the administrators there. And unless you are able to get the buy-in, you can't implement it. But so what I would like to say, stress on, is that DRI is a good tool to start looking at how do you take care of the antimicrobial resistance that the world is now worrying about and losing sleep on.
Thank you so much, Dr. Bishnu Panigrani, with us from the Fortis Hospital in India. I will again turn to the panel, and I wonder for Ms. Gulnaz Tariq, how important would you say that registers like this and data is for changing behaviors?
So for us, we say that no chatter without data. So if you don't have data, you can't really plan or you can't really talk anything. So data is very important. This is one thing. For anything, in the healthcare setting, data is the main key figure to drive you, especially for your present, your future, and what you have done in your past. Having said that, listening to him, I think what we can do is, like a new thing is to have rapid test on the bedside. For anything you want to prescribe as antibiotic, you need to do a rapid test. Because the delay is in the reports. What you send for culture takes 2 days. By then, if you have already prescribed, that can really, lead into, you must have, not known that you really need the antibiotic or it's just for prevention side. So if we have rapid test kits, which is available readily onto the bedside, can really control this in a way that everybody will get proper, or the usage of antibiotic will be, if it's necessary, then only. I think that is what I want to give a message. And then when it comes to the other prevention measures like hand hygiene. So in my facility, let's say, they'll say, oh, we have done the audit, but how you have done the audit? There's no tool which can tell you that how many times I have done hand washing. So I was thinking one day, like smartwatch. So it counts our steps. how many steps we have done, like 10,000. Why can't we count how many times we are hand washing? So these are the two things I think it's very important for the future to think of if we are heading towards prevention.
Even Professor Otto Carlson mentioned also that diagnostics is an improved diagnostics is an important. Is there something that the other people in the panel are wanting more diagnostics? Is that the key for?
Yeah. Yes, I think that's one of the important messages to take home, that we need to invest more in that. And as you mentioned, the technical side has been very fruitful during the pandemic. A lot of things were developed in a very short while. In this field of bacterial infections detection, I would say very little has happened during the last decades. And we need more investment. We need more research into this. What could be done? What's feasible? I think we've been too. How should I say it? We have expected it to be 100% sensitive testing. We need to accept lower rates of sensitivity. It's better than nothing. I mean, we need to take what could be done here.
More about good enough level.
Yes, we need to accept that good enough is good in this respect, because if you don't have anything, if you rely on culture, when you get your answer a few days later, when the patient's either has left the hospital or deteriorated in the disease, is no good actually. We need something else.
We actually have a couple of presentations on the theme of new medtech solutions. So I would like to welcome Ulrika Kolsrud, who is with us who is president of Health and Medical Solutions at Essity. Please give us your perspective on this.
Thank you so much. Well, the challenge is already clearly described by the previous speakers. The AMR threat is real and it's urgent. And it's also clear that there is not one solution alone that can tackle infections and combat AMR. We need to address this challenge at different stages, in different ways. And as many have talked about, we need to do it together. And when it comes to tackling infections at different stages, I would like to put the limelight on how to strengthen prevention. Now, the global pandemic that we're in the middle of has learned. We've learned a lot of things from it, and we should build on that and implement preventive measures, like installing hygiene infrastructures in healthcare and in society, and of course, expand access to clean water and sanitation. But let's not forget that we can actually limit the spreading of infections by something as simple as education on basic hand hygiene that we just talked about here in the panel, actually. Research shows that national hand washing behavioral change programs can give us a 35-fold return on investment in China and a 92-fold ROI in India. So a large part of what we do at Essity is focused on exactly this: solutions for and education on improving hand hygiene alongside with surface cleaning in society, in schools, at hospitals, etc. Even though now, of course, preventive measures are essential, we cannot avoid infections totally. And when they happen, we have to look at different ways of treatment, not the least in wound care, which is also an area where we are active. And at Essity, we are convinced that using wound treatment solutions that are proven not to lead to AMR over time is crucial. We are offering a wound care solution based on the innovative Sorback technology. And this one is based on pure physical mode to remove bacteria to reduce the bioburden in wounds, and hence not adding to the overuse of chemical agents. We are also driving antimicrobial stewardship programs to educate on the benefits of this technology as an alternative to antibiotics. And a vital part of that program is that we are collaborating with healthcare professionals to determine in which situation antibiotics are necessary and when other options may be as good or definitely better. Someone talked about the importance of data, and I think the clinical evidence and the health economic data from these programs speak for themselves. Sorback technology can reduce the rate of surgical site infections up to 68%. And the potential of binding bacteria in infected wounds is 5 times higher than with silver dressings. And routine use of Sorback technology in wound management can reduce the total cost of dressings by up to 50%. So our firm belief is that with the right tools for infection prevention and infection management, we can avoid the necessary spreading of antibiotics. So some of it, at least, with the right tools in infection prevention and management in wound care specifically. And this is on the top of our agenda. But we cannot do it alone. Nothing of this can be done in isolation. Policymakers, healthcare professionals, academia, and industry have to work together to raise the bar and to also speed things up. We therefore welcome the forums that have been talked about today. The Global Leaders Group on AMR, as well as the United Nations Foundation-led cross-industry group that we are a part of, and not the least a platform that we are joining here today. Combating AMR is something that we have to do together. And I would like to conclude by highlighting 3 calls to action. The first one being establish a prevention agenda. Every country has to establish actions for improving health, hygiene and sanitation with clear ownership on every action. And invest in hygiene and health. Something very close to my heart is that tenders should allow for innovations and should allow for digital solutions so that we can optimize the use of resources and improve patient outcomes. And then thirdly, to improve health and hygiene standards. Stakeholders at local, national and global level need to work together in order to establish hygiene and health standards and practices supported by education. And antimicrobial stewardship in wound care is a good example of that. That should be incorporated in care standards and practices, included in education of caregivers, as well as prioritized in financing and in usage. Thank you.
Thank you so much, Ulrika Kolsrud from SET for those perspectives. Let's get some more inspiration on how medtech solutions can be used to prevent infection. I know you talked about smart watches to hand wash. I think Karin Granqvist from Sahlgrenska University Hospital in Gothenburg will showcase another example.
Thank you for inviting me to talk about how to increase awareness of hand hygiene through electronic monitoring systems in healthcare. Despite substantial evidence that hand hygiene is important to prevent infections in healthcare, hand hygiene performances by nurses, nurse assistants, doctors, and other healthcare professionals remain suboptimal. Research suggests that hand hygiene performance can be improved through audit and feedback. Auditing hand hygiene performance among healthcare professionals and providing performance feedback can give them the information they need to change their behavior and to change their practice. Direct observations by trained observer are usually made to audit hand hygiene in healthcare, but this has been criticized for being costly and time-consuming, and for only capturing a small amount of the total hand hygiene events. Also, people tend to perform much better when being observed by an observer. In recent years, new technologies such as electronic monitoring systems have been developed to assess hand hygiene in healthcare. These technologies offer the potential to monitor hand hygiene events 24 hours a day, 7 days a week, and with much less effort than by direct observations. In 2018, an electronic monitoring system was installed on a ward at Karolinska University Hospital in Sweden, involving nurses and nurse assistants. Briefly, the system registers the use of hand disinfection before and after patient encounters. The system also gives feedback to healthcare workers consisting of adherence rates, and the feedback can be provided at group level as well as individual level. When we interviewed the nurses and nurse assistants who were users of the electronic monitoring system, they expressed that the feedback increased their awareness of hand hygiene, and they had started to reflect upon their own actions. I quote one of the participants, "When you get data relating to how you disinfect your hands, it makes you more aware. And you start wondering, when don't I use hand disinfectant?" The group feedback was perceived as good and useful among the users, but the individual feedback was considered even better. The increased awareness acted as a motivator to improve themselves. Raising awareness of infection prevention measures also increases knowledge of its importance. And increased awareness is important to be able to change behavior and attitudes. New technologies such as electronic monitoring systems can help healthcare workers to become more aware of their own hand hygiene performances. But we need more research on how to sustain this awareness and how organizations and leaders can facilitate the implementation and use of such new technology. And finally, one of the most important aspects of increasing hand hygiene, whatever method we use, is engaged leader that creates a strong safety climate regarding hand hygiene and involves all professional category in this work. Thank you.
Thank you, Karin Granqvist, who is a PhD student at Karolinska University Hospital in Gothenburg. So I struggle a bit here. We both talk a lot about the system and the policy and on almost a national and international agenda. And then we have this very hands-on program to help on the floor. If you were to prioritize, where does this fight actually have the best effect? Is it on the floor or is it in the government?
I think on the floor will be much better, because then, you know, the system which she highlighted, it will be good to have it, and then that will really increase the knowledge of nurses, how important it is, and all healthcare professionals, not only for nurses, for anybody who is dealing with patients, will be really good for them to, and then you can measure it. So that will be really good to adopt from the floor side.
Mm. What do you think, Ms.
Yeah, I totally agree. And I think it's one hospital at a time, one clinic at a time. So increasing the level of education and also managing the data and taking action every day to improve the situation. Because sometimes when we want to make a lot of policy changes and implement them, let's say nationally, they take much more resources and they take a lot of time. So on the other hand, we can also do a lot of consultative work. So on a smaller scales, we work with, for example, Karolinska University Hospital. We have done a lot of work with Karolinska last year. And we saw how we can improve the situation on the ground, you know, talking to the nurses and understanding the process and implementing the change and the, let's say, the behavior changes that are required in day-to-day action to get the best results.
Your Excellency.
Well, I think definitely the changing the perspective of individuals at the hospital level is important, but also it is important to drive this change from the policies and to monitor the performance of the hospitals. So, for example, each hospital will have antimicrobial stewardship program champions, but sometimes you see the priorities are different, especially when it comes to the private sector. So it is the policy and the regulation of this is very important. and being able to monitor and to have a data-driven performance is important as well, especially if you create some kind of competition between hospitals and have some KPIs to be monitored and compare the performance and the achievement of each hospital. This really helps to drive the change faster at the individual level. So the culture
So the
changes.
high level and the floor level needs to align.
Exactly.
Yeah. Yeah. Emma, do you have any thoughts about this as well?
I think it's everyone. You know, it's from the patient, the provider, and the payer. It's at all levels. Everyone has to take some amount of responsibility. I agree with what everyone has said, but it starts with empowering and engaging the patient. And that's where new technology like the digitalization era can help. We can reach much more people across the globe in many countries and educate them on the importance of hand hygiene. I agree we need data. We need, in the developed countries, such as in the US, there are penalties now for hospitals related to the HAIs. And some of that needs to be adopted in the other countries. We heard about low and middle income countries, where approaches that are considered standard of care in our developed markets are just emerging there, such as surgeons changing gloves before they close a patient, using clean instruments. At Moonlicker, we've been involved in a study looking specifically at that with 13,000 participants and really showing how in those low to middle income countries, we've been able to drive down the HAI rate due to changing gloves and using new instruments and closure. So again, data is key, showing it in people's own hands, in their own patients. And then ultimately, the payers and the policymakers. They need to make a stance. What are they paying for? They need to look at the total cost of the care, not just individual infections. And they need to reward the clinical institutes that manage it well, that not only have a policy in place, but actually make sure their staff are compliant with that policy and get their outcomes. And they need to tackle those that are not so compliant, that need to improve their outcomes in terms of infection. And so that's why I say I think everyone has a role to play.
I believe we have another professor with us, Pontus Now Clear, who will tell us a little bit more exactly one of those examples. Welcome, Pontus Now Clear.
Thank you very much. Can you hear me?
Yes, we can.
Yes.
Tell us a little bit about the HII proactive project, please.
Yeah. Thank you very much. I want to thank the organizers for the opportunity to present HII Proactive, a novel solution to curb healthcare-associated infections. We are at a crossroad in medicine where we risk that the advancement, for example, of cancer therapies are no longer will no longer be able to give these therapies due to the high risk of acquiring healthcare-associated infections with pan-drug-resistant pathogens. And if we look at Europe alone, it's estimated that 8.9 million healthcare-associated infections occur each year. And patients admitted to hospitals have about a 6.5% risk of acquiring a hospital-associated infection, often with multi-drug resistant bacteria. And it's estimated that approximately or at least 30% of these infections could be avoided if proper care was given. So in light of this, about 5-6 years ago, we initiated an innovation project financed by the Swedish Innovation Agency, a triple helix project working together with academia, public health institutions, and industry to work on novel IT tools for surveillance. And we also worked on change of workflows, and we worked on education. And the first thing of novel IT tools for surveillance very much aligns with what many of the speakers have been talking about today, about the digitalization of using data in a wise way. And also, as previously mentioned, we're now working with data-driven patient safety. And healthcare-associated infection monitoring should be carried out on a daily basis down to the individual level of individual patients in hospitals. And in this project where we have developed with the HII Proactive, we've developed models for validation of the effects of organizational development. And in this way, various efforts to reduce healthcare-associated infections can be introduced and quickly monitored for evaluation. And we're doing this by reusing electronic health record data in a smart way. So we automatically extract that data, and using both traditional rule-based algorithms and artificial intelligence machine learning, both have algorithms that can predict patients who will develop healthcare-associated infections and perform epidemiological surveillance or monitoring. And in that way, we can both predict on a patient level who will have it, so that health physicians and healthcare workers can perform measurements to reduce that risk, but also in a very smart and efficient way, monitoring changing of processes. For example, if a hospital start using a new intervention, rather than manually evaluating the effect of that, this system can then automatically give feedback to the hospital on different kinds of levels, from wards to bigger units to the whole hospital level on the number of healthcare-associated infections in an automated way. So we deliver reports on the risk situations at the hospital to management and doctors, so that they can adapt working methods and interventions to reduce the risk of infection. But we also deliver predictions about which patients are at extra high risk to doctors, so that they can prevent infections at an early stage. All of the development and validation that we're doing, all the algorithms are done as open source, and we publish them as peer-reviewed in peer-reviewed scientific journals. And you can also see that we're working on several different algorithms with regards to healthcare-associated infection, from sepsis, urinary tract infection, catheter-related infections, colorectal or surgical site infections, and pneumonia. We're also part of a larger network called the PRAISE Network, which is a constellation of European academic institutions that have produced a couple of white papers on how to perform automated infection surveillance in Europe. And we have the system up and running with installation at Karolinska University Hospital and Norrland University Hospital. And we're in the process to export the system to hospitals in Brazil, India, and Italy. And we're very interested to find other partner institutions that are interested in piloting the system we're doing. So if you are interested in working together with us on this, feel free to contact us for further discussion. You see there my email address if you're interested. Thank you very much.
Thank you so much, Pontus and Claire, for presenting this for us. So during these 2 hours, we have heard so many different ideas on how to tackle antimicrobial resistance, and both on a level, high level, and different medtech solutions and so on. If you were to implement, you were the leader of the World Healthcare System. If you were to implement one thing that tomorrow in the world, what would that be? I would start with you, Mr. Rush.
I would invest in education and digitization. I think that is very important to be able to have a right platform with the right educated mindset, and then measuring all the data and measuring the outcome of the educational measures.
Great. Your Excellency?
I totally agree with the investment side, because there are resources that are needed to strengthen our antimicrobial resistance, especially when it comes to the digitalization, AI, and predictions that can help really guide the doctors and the individual decisions.
Excellent. Ms. Gulnaz?
Yeah, I think that's a very valid point. So digitalization, I totally agree 100%. And coming from WHO to all world, what needs to be done in terms of preventing this? I think, the head of the healthcare has to bring it down. So buy-in from very top to the end. Even the developing countries, we need to support them as well. So then everybody, like adopting the same. So that's what I would say. Emma.
I think for me, it would be the realization that a small change can have a huge impact. We've just lived through a pandemic. We all readily wear masks. We readily wash our hands, use hand sanitizer. That wasn't the case 2 years ago. So I think it's really shown how a small change can have a big impact. And then I agree, using education to maintain that impact, because even when we come out of this pandemic, it is the hope that, the approach we take to infection control has improved for the future.
And Dr. Johan Carlson, you'll get the final word here.
I think we all realize that we need change on the basic level, on the floor. And to get that, a basic principle in communicable disease control is to try to acquire data for action. We need the data from the floor up to the top levels, going back, feeding it back to the people, but also using the data on a mega level, national, universal level, to see what could be done. So getting stable and very much automatic systems, because we don't want to impose a heavy administrative burden on the healthcare. We can't do that. We need to find digital solutions, automated methods to do it. But data for action is my suggestion for this.
So data, digitalization and diagnostics, I would say, summarizes your thoughts. And thank you so much for sharing your expertise. And I also want to say that you will be back on stage here in Johan Carlson, because I will ask you everything about the Swedish pandemic strategy here in 2:10, that is. We will see you. But for now, it is lunch, and that will be served outside in the lobby. You can bring it in here if you want. The official program starts again at 2:30 in Dubai time, and that is, I think, 11:30 Central European time. And but as I said, already at 2:10 or 11:10, that is then in Europe, we will have a discussion on pandemic strategies here. So please welcome back and enjoy your lunch. Thank you.
With urbanization intensifying, unmanaged risk of infection in healthcare, and an aging population, the threat posed by infections and their potential to spread is increasing. As the world struggles with the ongoing pandemic, our ability to prevent infection will be tested like never before. And when treating infection, we must do so in the face of rising antimicrobial resistance, higher incidence of chronic diseases, and resource scarcity. But things can be bad and getting better. As global awareness of our challenges grows, adoption of proactive and preventative health strategies at home, in offices, and on the ward grows with it. Digitization of healthcare is allowing us to learn and develop, enabling us to innovate the way we clean, how and when we wash and sanitize our hands, diagnose and treat infection. We need to rethink what we've always done and realize what is possible. The innovation and transformation of healthcare through digital solutions and wearable tech can support health monitoring and support families and people at home, reducing pressure on caregivers. But it takes more than products to prevent infection. It depends on all of us working together, locally, across borders, and between private and public sectors, building awareness to accelerate change with a higher impact. Together, we will transform healthcare. At Essity, we actively engage in dialogues about sensitive healthcare issues, which is fundamental to reliably improving hygiene and health standards.
One in every 10 patients suffers from healthcare-associated infections worldwide. This leads to significant mortality and financial losses for health systems all over the world. By preventing infections, millions of lives can be saved every year. Microbes that adhere to a surface often form a biofilm, which protects them from antibiotics and the patient's own immune system. This increases the risk of infection. However, it is possible to prevent microbes from building up on the surface of medical devices. Bactiguard's infection prevention technology is based on a noble metal alloy coating that consists of a thin layer of gold, silver, and palladium, firmly attached to the surface of medical devices. When in contact with fluids, the noble metals create a galvanic effect that repels microbes. When fewer microbes adhere to the surface, there's a decreased risk of infection. The unique Bactiguard coating is not only fighting infections, it's also tissue-friendly due to its non-releasing mechanism, as opposed to traditional coatings that often depend on the release of substances that kill both good and bad microbes and might harm the surrounding tissue. Bactiguard's infection prevention technology increases patient safety and reduces the risk of infection.